So there's some very interesting data this ASH. I participated in an abstract looking at Burkitt lymphoma specifically, which is a very aggressive lymphoma, area of unmet need. So two abstracts, one looking at outcomes with various different high-dose chemotherapies, showing a difference between doses of EPOC, hyper-CVAD, and R-Codox-M IVAC favoring more intensive regimens. The abstract I was more directly involved with looked at CNS events. So first identifying, it was 26 centers with about 556 patients with Burkitt lymphoma, so a very large registry. We looked at risk factors to identify patients who potentially may have higher risk of CNS involvement at baseline, so more advanced stage, poor performance status, both were predictive of having baseline CNS involvement. But interestingly, patients treated with dose-intensive therapy did have different rates of CNS relapse. So EPOC, dose-adjusted R-EPOC with IT intrathecal chemotherapy is a standard of care, as well as hyper-CVAD and R-Codox-M IVAC, which are more intensive chemotherapies. So we saw in patients treated with EPOC, rates of CNS relapse at 3 years were higher, around 12%, compared to the more intensive regimens, R-hyper-CVAD or Codox-M IVAC, otherwise called McGrath, with rates around 3 to 4% at 3 years. And this was statistically significant with a hazard ratio of 3.5, favoring more intensive chemotherapy. And it was independent of their baseline CNS involvement, which I think was quite unexpected result, and then also independent of their baseline otherwise poor prognostic factors, which would be performance status or HIV status. So I think the retrospective, a large cohort of over 550 patients with Burkitt lymphoma is important and may start to change how we think about treating these patients in the upfront setting.